Hello, everyone. My name is Murdoch Erie, and with me today, no man named Greg McKettrick. He's the guy that knows everything about men's health, ED, and everything else in between. So, Greg, thank you for being here. This is a second part to our series. There's one more part that we're going to do the same time next Tuesday, and Greg is going to be presenting that. So, Greg, how you doing today?
I'm doing great. Hope you are.
All right, I'm doing fantastic. So, we've got a few people. I had a text message from a couple of people. They're saying that they're on their way. So, we'll
Okay.
just let them in as they arrive. So, Greg, I think you can share your screen with. Let me just make sure. Share. Yes, you can share your screen if you like, and you can start your presentation, and then we'll just let the folks in as they come in. All right,
Okay. I'm going to back off of this for 1 second.
no problem. So Greg has a wealth of information when it comes to this topic. He's a liaison for the Revelation Health. I'll let him introduce himself. But last week, when we're talking about the topic, I really enjoyed everything that he was talking about. As a pharmacist, I found it very informative and interesting. And some of the things, believe it or not, I did not know myself. So I learned quite a bit from Greg. So, Greg, whenever you're ready, it's all yours.
I'm working on it.
All right, no problem. So you can see our website. Our company name is RX Connection. We are a technology company for pharmacies. We provide many solutions to pharmacies, such as educational engagement tools, analytics, telemedicine program, supply chain and marketing, and compliance. So if you're looking for semaglutide and GLP-1 products, this is a place to go because we give you the telemedicine, the uh, the GLP products, and the marketing you need to go with it. And we have a whole department dedicated to marketing and also podcasting. So please be sure you check our website. There's a wealth of good stuff in there. I've had
Hey guys, this is Greg McKettrick
Oops.
and the Revelation Pharma Mensa.
has helped their pharmacists. So are you having any issues, Greg, or
No, I think I've got it up there. Can you see that?
not yet? Let me stop share. There we go. There you go. And if everybody can see the Greg screen, then Greg, this is all yours. Go ahead.
All right. Um,
And if you could just do the slideshow, and then so he gets a full screen, that'd be
Yeah.
great.
yeah, trying to get there. Okay.
All right.
So,
Hey guys, this is
There
Greg.
we go. Fantastic. I can just see it all.
is that okay there?
Yeah, just great.
Okay.
Yeah.
All right.
If you hit
So,
the slideshow, I think if you hit the
yeah.
slideshow from the beginning, I guess the left hand side, yeah, gives you a full screen.
Guys,
There you go.
Greg
That's
McKettrick
much better. Yeah.
and the Revelation
Unfortunately, it's
Pharma
doing the whole
Mensa liaison.
presentation because this is a
And
recorded presentation. So I'm going to come back off of that.
Sure. No problem. Thank you.
So I'm going to go with this right now. Otherwise, I'm going to have your guys are going to be listening to my whole audio. As a refresher, last week we were talking about erectile dysfunction and a lot of the basic treatments, a lot of the definitions in terms of what ED is. Some of the information I think is pretty basic in terms of, what is ED? Well, inability to maintain a satisfactory erection. That's pretty simple. There's more clinical diagnoses than that, but bottom line is if it's not satisfactory to the individual, then it's an issue. And that encompasses other things as well. So, we do talk about premature ejaculation, about anorgasmia, even Peyronie's disease. Performance anxiety in terms of all of these different issues. A lot of what we talked about last week had to do with the oral medications, like the typical PDE5s. And then how we can incorporate those into some compounded versions, which are the sublingual troches or oral dissolving tablets or rapid dissolving tablets, depending on terminology, where we're using either the individual PDE5, combinations of PDE5s, or even combinations with other ingredients like oxytocin or testosterone or apomorphine. Oh, we kind of slid through a good bit of information on that last week and got up to a point where we were talking about some of the I guess the more topical type issues in terms of what can be used. And just in terms of what I've been working on currently, just kind of fell in line with this. So I thought I'd mention it. There's a lot of different options. And I get asked by patients and by doctors probably half a dozen times a week, is there no topical treatment for erectile dysfunction? And, everybody would love to have something where they can basically apply a cream or a gel to the skin and really get the kind of benefit that they're looking for. And there are options. There's just nothing that has knocked the barn doors off so far. There's currently an OTC product, and I won't say it's the greatest thing ever, but it has been approved for sale in the States by the FDA. It's Eroxon, and it's a topical ED product, and it essentially uses counter irritants and fast drying alcohol base to create a temperature variation on the penis, inducing increased blood flow and thereby allowing for people to get an erection. It was researched a great deal in Europe before coming to the States and had some pretty, satisfying tests. In reviews of patients here in the States since it's been released for sale, I won't say that it's underwhelming because I don't know that anybody really expected it was going to be, again, this huge product, but it just hasn't really rang the bell. We're not seeing where people are getting huge response other than, maybe some mild response for mild ED. There are other options, and there's some options that I've tried. I mention this only because, again, I do get a lot of questions about topical. There are some products in Europe that use alprostadil or prostaglandin topically, both for men and women. And I have compounded this in the States. I've used this for treatment of ED and for female sexual desire disorder. Again, the problem is getting absorption through the skin into the vascular bed of the penis is really, really challenging. So again, the topical for the men, that product using the alprostadil has not really proven to be terribly successful. As a interesting anecdote, I'm currently working with 2 different universities on a research project where we're looking at incorporating nanotechnology into this process. And we have reason for hope that will be an effective way of incorporating topical ED treatments, bringing some of these medications to where we can actually get them into the vascular bed appropriately. Interestingly enough, the topical alprostadil for women, the vaginal tissue, clitoral tissue is much better route of absorption. So we do see significant effects as far as the female population. We just can't really get good absorption in the men. And so that's going to bring us up to where we are today, to products that I'm assuming you guys are fairly familiar with. Let's see if I can get in here. No, I can't do that either. So just want to see if I can get a full screen on this so you guys can see it better. I hate this. No.
Yeah, folks, if you're looking for last week's presentation, part one of our discussion about men's health, you can always check our YouTube channel. We have all of our past webinars and things posted on our YouTube channel. I put the link over on the chat right now if you want to save that link, or just go to YouTube and type in RX Connection, and you'll be able to, view all the past episodes and things like that, and watch it at your convenience. We're sorry, Greg's having a little bit of I don't know what happened to his computer, but something did happen. He said he'll be right back, so just hang in there for a couple minutes. Well, let me, while we got you here, I know some of the folks that we have in here is basically, this is our YouTube channel. This is last week's webinar that you can watch at your convenience. While Greg is checking his computer, let me tell you about RX Connection and what we do. Well, I'm a pharmacist, as most of you know who I am, and I own several stores. They're all, national brands that I sold the end of 2016 because of DIR fees. I could see what was happening. So I kind of got smart and I said, well, this is the time to, get out of this dispensing thing because it's not going to go well. Now, we had a very busy practice in all 50 states, mail order, compounding, you name it. So this RX Connection idea, that's always been around since 2005. I've been in technology field since 2005, and we developed a whole bunch of technology-based services for pharmacies that spans from telemedicine, as I was telling you, from analytics. So we have engagement tools. So with RX Minder, it is a program where you can send a educational audio through text messaging that your patients can listen to and at any time. The text message that's sent to your patient it's all custom to your pharmacy. It has your logo. It has links to your website. They can dial a phone number. They can have other links to other part of your website. It's a nice little program that you can educate your patients, and that's in any language. Of course, RX Podcasting is another program that we provide. And RX Podcasting, you say, why podcasting? The podcasting idea has been around a long time, maybe for decades. And basically, podcasting can be a great tool for your pharmacy to educate, to build trust within your community, make you a subject matter expert in whatever your field may be or your expertise may be at your pharmacy. So podcasting can be a huge game changer for your pharmacy, simply because you connect with your patients in a lot of different ways. And to create podcasts with our system is very simple to do. Only takes a few minutes a week, and you're all set. Looks like we got Greg back. Yay. Hi,
Hey,
Greg.
Greg. All right.
All right. So I think you can share your screen now.
I'm there.
Yep. Okay.
As good as I can. All right. So as
Yeah.
I was saying, I apologize for the interruption there.
No problem.
Hopefully down the road, topical ED products will be something that's real live and very efficacious. But for right now, that's not really the case. So next best thing, maybe the intraurethral options. So commercially available product, Muse. If you've ever worked retail and dispensed this, it's a urethral suppository. It is an alprostadil suppository. Historically, the available strengths have been 125 micrograms, 250 micrograms, 500 micrograms, and 1,000 micrograms. Currently, I don't think they even have the 125 available. So again, we're going to get into some of the basic drawbacks here as far as, what are we using and how effective is it? The great thing about Muse, as opposed to some other treatments, people who can't tolerate PDE5 medications for whatever reason, whether it's a medical condition or a contraindication due to other medication therapy, this is a therapy that they can use that really isn't going to interfere with any of their other therapies. The negative to Muse is that the urethra is not a very good route of absorption. It's actually a very poor route of absorption. This is exhibited by the difference between the doses that you see for the urethral suppositories compared to what you would see for a penile injection. There can be a 100 times difference in concentration. I've actually put in here 1/10, but that's like a maximum dose compared to minimum dose with the Muse versus the penile injections. So the way this works, you insert the pellet into the urethra. It is absorbed, hopefully, into the bloodstream and allows for vasodilation, which will maintain the erection. It's not terribly comfortable. The other part of this is if there is any chance that the partner is fertile, you have to wear a condom. There is literally no safety information in terms of the use of this with a ovulating female. So it's generally best you just tell patients use a condom when using this product. The discharge of high concentrations of the prostaglandin could potentially be harmful. It can be a compounded product also. And, from the compound side, we can either kind of duplicate the strengths of what the Muse offers using just the prostaglandin, and it might be in a gel, which is a little easier, I think, than using the suppository form. Also, they can do this in combination using different vasodilators, very similar to what you'd see with penile injections, where instead of just L-prostadil or prostaglandin, you can also use papaverine and phentolamine and put those concentrations in there to see if you can't get the desired outcome. In the years that I have been doing this in compounding, I will tell you that this is not a first-line treatment for pretty much anybody. The patients that want to use this typically are just deathly afraid of doing a penile injection and cannot, for whatever reason, either they don't respond to or they cannot take the PDE5 medications. So again, not something that's ever been really super popular, but it is available. It's out there. More so in terms of effectiveness and popularity are the penile injections. Now, from a commercial standpoint, you're probably familiar with things like Caverject and Muse, and that is the same type of a thing. Generally speaking, what happens is patients who either are no longer responding to PDE5s or they cannot take them either due to side effects or due to other medication therapies or medical conditions, they turn to the penile injection as the best answer in terms of getting a response. And when these things are dialed in right, they really are. They are super as far as allowing for erectile function. We typically are using, again, the same basic vasodilators, just like what you saw with the Muse or the compounded urethral gels. So whether that's just prostaglandin or a combination of prostaglandin with papaverine and phentolamine, they do vary. It's a very simple process as far as how this is done. You're using either a small insulin needle or a tuberculin needle. It's injected at the base of the penis, and you'll see here in this little diagram, this is kind of a cut through of the penis. So the top side of the penis is your 12 o'clock, the underside or where the urethra is at the 6 o'clock. And then you can see there's two chambers within the penis, and that's the corpus cavernosa. And that is a cylinders which run within the penis full of a spongy material that engorges with blood once you actually establish significant blood flow. That's what allows for the erection. That tissue swells up, it compresses the walls of the corpus cavernosa against the skin, which blocks off the blood flow leaving so that the blood is retained within the penis. Those blood vessels are literally kind of crimped so that they can't release the blood. The injections typically take 10 to 15 minutes to come into effect. And then the goal is to have an erection. It's going to be 45 minutes or so. Once we kind of get that dialed in. So again, the commercial products that are out there are your Edex, which again is the prostaglandin, or the Caverject, and you can see the strengths of these: 10 micrograms, 20 micrograms, 40 micrograms. Now keep in mind, again, I mentioned this before, but the strengths of the Muse suppositories: 250 micrograms, 500 micrograms, 1000 micrograms. So, I mean, you can really see that the difference in absorption when you're able to get that medication delivered into the corpus cavernosa is significantly better than trying to get it through the skin or even through the urethra. The commercial products are great for a number of reasons. One, it doesn't require refrigeration. You know, it's a room temperature product, so it's literally a ready mix when you take it. The negatives to this: one, it's a single ingredient product. So it's just the prostaglandin, which can be super. It can be great for a lot of patients. Other patients are very sensitive to prostaglandin. Prostaglandin can cause discomfort. We know that. So, you know, when you're injecting prostaglandin into the penis, you can get some burning and stinging. And some patients, somewhere around 20%, 25%, are very sensitive to those types of injections. Others are not. The other thing about the Caverject, since it is a single ingredient entity, we don't always get all of the response that we need in certain cases. It's a great test for patients to see how they will respond. And then based on that, we can start incorporating the other vasodilators to see if we can't get a better response. The third negative, unfortunately, is cost. So the Edex and Caverject, if insurance doesn't cover them, they are really, really expensive. And I can't tell you how often I'll get a referral from a physician who says, well, I've prescribed Edex for a patient, but they can't afford it. What are my options? Well, that's the nice thing. Again, you come into compounding and, you know, we are able to, at a fraction of the cost in terms of paying cash for the commercial products, compound either a single ingredient like a straight prostaglandin, or patients who are really sensitive to prostaglandin will sometimes go without that particular ingredient, and they'll use like what's called a bimix, which would be papaverine and phentolamine in combination. You don't always get enough of a response from bimix, but it does not cause discomfort. So, you know, if the straight prostaglandin is giving a response, but it's causing discomfort, we can go to the bimix. If that is not giving enough response, well, then we can go into a trimix where we're actually using a combination of all three of these. But what it allows us to do is kind of tailor the quantities of each. So if we get enough response with a lesser amount of that prostaglandin, we can generally allow for less discomfort with the shot and rely on the papaverine and phentolamine to really kind of bring up the rear with it. In some cases where we have to go with higher doses of prostaglandin and we're starting to get some discomfort, we'll actually go into a quad mix, which in addition to the prostaglandin, papaverine, and phentolamine, will incorporate an atropine. And the atropine helps by relaxing the smooth muscle, so it can ease the formation of the erection. And a lot of times that actually takes away a lot of that discomfort. So a lot of options in terms of being able to address this. The other part is through compounding, we can really adjust the dose, not only the dose volume, but the concentrations of these different medications. And, by working with this, we're able to establish what is going to allow for the most firmness, the correct duration, and the least discomfort. So, we know prostaglandin really it's the strongest of these, but also can cause the most discomfort. Papaverin really adds duration to these mixtures. In some cases, too much. So we really kind of have to tailor how much that we're using in combination with the prostaglandin. And then the phentolamine really helps to augment the other two. And it allows us, like I said, to kind of tailor this to the individual patient's needs. I'm going to show you another slide, and it's a messy slide. It's going to be difficult probably to really understand it. And what I would just tell you is this flow chart represents the thought process that I go through when I'm working with patients. If you go to the very top, that first top blue square box, I know it's hard to read, but in most cases, when I'm making recommendations to physicians, my recommendation is to start with just the prostaglandin. The reason is it is the most predictable of the vasodilators. So we see the least of a priapism issue, meaning an erection that just won't go away. You hear about priapism, erections lasting more than 4 hours. And, in all the years using the patients or dispensing Viagra and Cialis and that, I don't know that I ever really had a patient come to me with severe priapism from using the PDE5s unless they were combining other things with it. But with the injections, if this is not done correctly, that is a huge issue. So we really have to pay attention, and we start with very low amounts and then work our way up. So as we flow through this chart, basically, just like I was saying before, if prostaglandin works and it is comfortable enough, great. We just adjust the dose. We typically will see somewhere in the ballpark of about a 45-minute erection, ideally, which, in terms of what a lot of us anticipate, that can be pretty phenomenal. It can allow for very satisfactory intercourse or sexual response, allows for plenty of time for foreplay, possibly even, more than one round of intercourse. So, it's nice that we don't worry too much about the priapism with the prostaglandin, but again, we do have to tailor that dose. Now, if we get pain, like I mentioned, we can go to a bimix. If we're not getting enough of a response from the bimix, we can go to the trimix. And then we can tailor these doses. We add other components. In severe cases of erectile dysfunction, we'll even start to incorporate other therapies. And this is not for somebody who's starting this process right off the bat. A lot of times when I'm seeing patients who have gone through prostatectomies, prostate cancer, spinal cord injuries, where they are really at the end of the spectrum in terms of erectile function, we will start using the components like the trimix along with PDE5s. Another condition, it's called venous leak, when the blood vessels that feed the penis no longer have the capacity to retain the blood. We have to overcompensate for blood flow and blood loss. So, we start to really work with a lot of different aspects of it. So again, this is just kind of the Greg's brain on drugs in terms of how you treat ED, this kind of flow chart. And like I said, it's complicated, and it's something that if you get into this part of it, call me, because I can certainly help you with that. Now, other therapies. We've kind of gone through a lot of this as far as, the oral medications, the sublingual medications, using the supplements, the vasodilators, whether they be intraurethral or the injectables. So for a lot of patients, they just really don't want to use those medications, or they can't, for whatever reason. Maybe they are intolerant to the injections, or have started to see where the injections are just not as effective anymore. They can't take the PDE5s, again, like for all the reasons we've discussed. So for them, the old standby, the VED or a vacuum erection device. And, we use these a tremendous amount for physical therapy because when I have patients who are either post prostatectomy or have been celibate for long periods of time, and I mean years and years without erectile function, penile rehab is extremely important. And that means getting blood flow started again, getting that tissue stretched back out, getting those blood vessels fully perfused. And this is where the vacuum pump can be extremely beneficial as a physical therapy device. But it can also be used for intimacy. The pump itself, it's pretty simple mechanism. You insert the penis into the cylinder becomes a vacuum with the pump head, whether that's a manual or battery operated pump. So all the air is pulled out, which pulls the blood into the penis or pushes the blood into the penis in the vacuum. And then once the penis is fully engorged, you incorporate what's called a retention ring, or commonly known as a cock ring. Good vacuum pumps actually will incorporate the ring to where it is attached on the end of the cylinder so that once the erection is achieved, you don't have to release that suction pressure in order to put the ring on. The ring itself acts as a tourniquet. That means that it is going to maintain the blood in the penis so that it is essentially going to be firm enough for intercourse. The rings can be used independent of the pump. In most cases, the pump really augments the effect of it because it allows you to get the erection and then put the ring on. For some men, they can get an erection, they can't maintain it. So if that's the case, they can use the ring, the retention ring or the cock ring, as a device to maintain the erection and allow for intercourse. The ring itself can be left on for a period of 30 minutes. Now, you can't leave it on beyond that. And then after that point, you have to leave it off for at least an hour. And pretty simple reasoning here. While that ring is intact, there is no blood coming in or out of the penis. So that blood that is in the penis maintaining the erection becomes completely deoxygenated, and you start getting into a situation where the tissue's starving for oxygen. So, after 30 minutes, the ring has to come off, and then you have to wait a while unless allow the good blood flow to come back in there before starting over again. Another device that can be used successfully, and this is for the penile injections. A lot of men, in fact, I'll tell you probably 95% of men, when I talk with them about penile injections, first thing out of their mouth is, "You want me to do what? And you want me to put a needle where?" And they look at me like I'm crazy. And it takes a couple of times, and then they tend to kind of get the hang of it, and it's not such a big deal. It's a tiny little needle. But for some, it's just not something they can do. Either they're extremely needle phobic or they don't have the dexterity. In some instances, because it is encouraged with penile injections that they alternate left and right side, some people just can't do, if they're right-handed, they can't do a left-handed injection. Or if they have had a stroke where, again, they've lost some function or some of the dexterity, that becomes very challenging. The auto injector is a spring-loaded device that allows them to do this injection. You pre-fill the syringe goes into the injector, you press the injector against the side of the penis and punch a button. It does the injection for the patient, which actually serves a number of purposes, not only the fact that, in terms of dexterity, but also there is an issue with penile injections as far as the depth of the injection. If it's too shallow and it doesn't penetrate that corpus cavernosum, it doesn't get into that membrane, it becomes what's essentially a subcutaneous injection. And the medication, the vasodilators, are deposited under the skin outside of the corpus cavernosa. No way it will be effective. It can't absorb through that, and you'll have a little bubble that will dissipate within typically 1 to 3 days from the side of the penis as the body just reabsorbs that liquid. The auto injectors are calibrated to always deliver the medication at a predetermined depth. And that's determined based on what type of a needle, how long of a needle, what gauge. But the nice thing is there's no question in terms of whether or not it's going in deep enough. It's positioned alongside the penis, hit the button, and it goes in correctly. So that in and of itself can be a great relief for a lot of patients. The other option in terms of a surgical option for patients where, again, this is really the end of the line where, you know, they've tried, or hopefully they've tried all the other therapies. And I'll tell you a little story about that as well. You know, generally speaking, once patients have kind of gotten to the point where injections aren't working, maybe the vacuum pump is just too cumbersome, they can't take the PDE5s, or the PDE5s are not effective. You know, the next option on the table becomes a penile implant. And penile implants can be lifesavers as far as intimacy and quality of life are concerned. We do see a fairly high percentage in prostate cancer patients when there's been non-nerve sparing removal of the prostate, meaning that they don't have any nerve retained after the surgery, which allows for very little in terms of natural function. And this is a pretty major surgery. Patients are out of commission for several months afterwards. As I mentioned, there's 2 chambers of the corpus cavernosa, and in a penile implant, there are inflatable cylinders that are implanted in those chambers. They run into the body, are connected inside where there is a saline bladder. The bladder is in turn connected to a pump, and the pump is actually located in the scrotum. So when the patient wants an erection, they pump the device which is in the scrotum. It pushes the fluid from that saline bladder into the implants and allows them to have an erection for, quite honestly, for as long as they would like to have it and as frequently as they would like to have it. Again, it is mechanical, but for a lot of patients, it is, you know, kind of the be all end all when it comes to the end stage treatment. The devices, like most things, you know, you talk with a doctor, an orthopedic doctor who's talking to you about doing a knee replacement, they basically tell you, you know, hold off as long as you can because we don't want to have to do this twice. Well, same basic thing follows with this. We try to get patients to use every option possible up to the suggestion or discussion about the implant, simply because these are mechanical devices, parts wear out. So, you know, after the implant surgery, they might get 8 to 10 years before things have to be redone. And, you know, again, it's not a real pleasant surgery and it's not inexpensive either. So most of the time when we're talking to doctors, we try to encourage them to exhaust every option for the patient. There are some doctors who specialize in this, who really push patients to this very quickly. And a lot of times we're able to intervene and, you know, let the patient know that there's other options that we could try beforehand. Doesn't mean that all of those options are going to be successful, but I always like to let the patient know that they've at least attempted everything possible. Now, this is something completely different. And this is why when you spend all your time researching sexual function and dysfunction, you come across some funny stuff. I saw this and thought it was a joke. This is the Brazilian wandering spider. Well, guess what? A bite of the Brazilian wandering spider is said to will create an erection that will last up to 4 hours. And, you know, lots of jokes on the internet about this. But I started reading more and more about it. And sure enough, scientists are actually doing research now. The venom of the spider is a very potent vasodilator. So starting last year, they were doing research looking into the viability of the venom as an actual treatment for erectile dysfunction. Personally, I'm going to stay out of the jungles and we'll see what kind of research they come up with. But, you know, it's nice to know that, you know, we're always looking to nature for our answers. So here's kind of the next stage. And I realized that, you know, you might not consider premature ejaculation part of erectile dysfunction, but really and truly it is. it affects the most men. It is the most common underlying condition contributing to dissatisfaction in terms of erectile performance for men. It affects the highest percentage of men. And when I say that, I'm talking about up to 75%. Now, that being said, the standards of measure for premature ejaculation are surprisingly modest. So average, what they call the IELT, or ejaculate latency time, basically meaning from the time of penetration until climax, average around the world is about 5.5 minutes. So, you heard me talk about some of these penile injections where, you can expect a 45-minute erection. So you can imagine that, if your average is 5.5 minutes and you're comparing it to that, boy, that's pretty dramatic difference. In all honesty, premature ejaculation really is when it's an almost immediate or within the first minute, they call severe PE. A minute to 2 minutes is actually mild PE. And then 2 minutes to 5 minutes is just modest. It's minor. So, what we're really focused on are situations where there's so little time from penetration into ejaculation that there can be no enjoyment. And it can be extremely frustrating for both partners. And because of that, this is a segment of the erectile dysfunction or sexual dysfunction that really deserves a lot of attention. So again, many components to this, both psychogenic and biogenic, meaning there's psychological issues that are combined with actual biological or physiological issues that contribute to premature ejaculation. So some of the more immediate issues can be part of what I call that negative feedback loop of ED. So you've had a bad experience, which now gets into your head and you're developing performance anxiety, and this is feeding this whole issue. This can be due to prior experience. It can be to a history of experiences, or something that went back into your developmental ages, puberty and adolescence. In addition to that, just general anxiety can be an issue. Lack of understanding of sexual technique can be an issue. One of the things that we look at in terms of ED is, the different lifestyle or modification changes that can be made in terms of establishing or improving ejaculatory control. As I mentioned, inexperience. So, just overexcitement can be an issue, or infrequent sexual activity can be an issue. There's also links with testosterone levels. So it's been shown that patients who have high testosterone levels have a predisposition to premature ejaculation, which makes kind of a little bit of sense since that's really that desire and the excitement. So in addition to that, there are the biogenic or the biology factors. There's actually an established genetic root or hereditary factor with premature ejaculation. Studies have been done actually looking at twins within a family, showing the high percentage of recurrence with PE. And this can be a lifelong condition if it's a genetic situation, as opposed to something that develops due to experience or anxiety. So again, lots of different contributing factors that play into this. Possibly, like I said, it's nervous condition, or call it the nerve bed condition, where there's hypersensitivity. Also could be hormonal issues. So lots of different factors that play into it. In terms of treatment, the simplest and probably the most well-known are kind of the behavioral modifications. So I work with a sexologist with my patients when we're trying to reestablish intimacy in couples. And one of the first things that we'll talk about anytime this issue comes up are, the stop and start technique or the squeeze technique where you actually pinch the penis when you're starting to feel like you're about to climax. Stop and start, you interrupt intercourse until that feeling of the impending climax passes. Another possibility is actually masturbation prior to expected sexual activity so that you have more of a latency period, a more established latency period. From pharmacology, there's a number of things, and I'm sure you've certainly seen this, and the drugs that are used to treat PE are typically the same drugs that cause either ED or anorgasmia in patients. Makes sense, right? So if your issue is that you are climaxing too quickly, taking a medication that tends to retard sexual function would make logical sense. Commonly used are medications like SSRIs, so Zoloft, Paxil. In studies, the SSRIs really work very well if taken on a daily basis. Paroxetine has been shown to be the most effective. Not the greatest for PRN use or, using it just prior to intercourse. Other medications like the non-selective serotonin reuptake inhibitor, like clomipramine, that can actually be effective both as a daily and actually as a PRN, taken about 4 hours prior to sexual activity, can be very effective. In addition to that, there's over-the-counter numbing agents like benzocaines and lidocaines. They just kind of desensitize the penis, and they can help to prolong the latency period. And then medications like PDE5 inhibitors, tramadol is a big one, and even the penile injections. Sometimes the PDE5s and the penile injections are used because they restore confidence. They get over the mental block side of things. And that can actually allow for the ability to overcome the anxiety or the performance anxiety that's feeding into the premature ejaculation. And here you have kind of this description in terms of the effectiveness of these medications. IELT, that is the amount of time from penetration, from vaginal penetration until climax. So you can see daily paroxetine, very effective, increasing that time by 11-fold. PRN use, maybe twofold. So not going to be the greatest, especially if you're talking about, going from a minute or less. Going to 2 minutes isn't a huge jump, but, going to 10 minutes or 15 minutes, that's pretty substantial. Clomipramine can have a 4 times increase, and that's even just as a PRN dose. So again, much more effective taken as a on-demand medication than are the SSRIs. And then it's been established pretty well that the combination therapies using any of these above in combination with other things like the PDE5s really show marked improvement. And again, as we talked about before, a large component of this has to do with psychological influence. So improving the confidence is a huge factor. In my opinion, if we can avoid putting people on these daily medications, unless it's justified, unless there's an underlying reason for it that really supports the use of an antidepressant in a particular patient, man, it'd be great if we can avoid that. If we can use the least intrusive methods first, typically, like I talk about in all of these therapies. So, starting with either the numbing agents or condoms that are lined with benzocaine prior to going into any medication therapies, using the stop and start method or the squeeze technique. And if not, then, jumping into some of these like the PDE5s, because, not only do they promote erectile function, but, the ability to really shorten the latency period in between erections is improved. And same thing with penile injections. On top of that, they boost performance confidence. So if we get people to where they're not worried about their ability, then they can a lot of times kind of get over this if it's not a actual genetic causation. And then incorporating these different medications together, using these in combination is really going to give for the overall best benefits for the patients. Dad, do you want to hold off from here?
Yeah, I was gonna say, let's pause here and everyone, you can go to our website and you can register for next week's or the final episode or presentation of Greg. We're gonna talk about telemedicine. We're gonna talk about other topics that Greg is gonna be talking about. So just stay tuned and let's just pause here, Greg, and then we'll rejoin again next Tuesday at 1 p.m. and we'll continue from here. Okay.
And again, I apologize for the technical
Hey,
difficulties.
no problem. And if you want to watch this video, this will be on YouTube by later on today or after tomorrow afternoon. It will be on YouTube channel, so you can always watch it on RX Connection YouTube. Thank you, Greg, and we'll have a good 4th of July. Stay safe, and everyone, and we'll talk to you all next week.
Thanks, guys.
Okay. Thank you. Bye-bye.